Hi, I'm Dr. John Emil Kenny, and I'd like to welcome you to my first chapter entitled The Mechanics of Ventilation.
So let's start talking about pressures in the respiratory system as it pertains to the mechanics of mechanical ventilation. So it's absolutely imperative that the pleural pressure be understood by the intensivist, because really pleural pressure is a surrogate for, and I'll use interchangeably for, intrathoracic pressure. Now it's true that pleural pressure will vary regionally within the thorax and around the pericardium, but for the most part, in order for us to easily understand or easily digest this information, we'll just treat pleural pressure and intrathoracic pressure equivocally or equivalently. Sorry. And as I mentioned, the pleural pressure is the approximate pressure in the interstitial space around the airways. It's also the pressure around the esophagus. So when you drop an esophageal probe, that's what you're using as a surrogate marker for pleural pressure, is the esophageal pressure. And as well, as I mentioned, the pleural pressure is the pressure just surrounding the heart and the great vessels. So this pressure is a key determinant of mechanical heart-lung interaction. And as I'm saying here in very flowery speak, it's in order to understand these cardiocirculatory interactions, pleural pressure is imperative to understand. So simply speaking, there's two kinds of pressure within which are, I guess, kind of subtypes of the pleural pressure. And this pressure is generated by the muscles of respiration or applied by the ventilator at the proximal trachea. And the first type of, quote-unquote, type of pressure is the pressure required just to maintain a lung and chest wall volume. And then the second kind of pressure is the amount of pressure that must overcome the frictional and viscous forces to drive gas flow. And I'll refer to these as static and dynamic pressures, respectively. And as this chapter 1 moves on, I'm really going to break this talk down into 5 parts. And the first part of chapter 1 will deal with the static aspects of the lung and chest wall. And when I say lung and chest wall, I'll frequently refer to that as the respiratory system. That is, respiratory system will be used synonymously with the lung and chest wall together. So the first part will look at the static aspects of the lung and the chest wall. And then the second portion of this chapter will deal with the dynamic aspects of ventilation. That is the pressure that is used to drive gas flow. And then I'll use these static and dynamic aspects of pressure to introduce the Campbell diagram, which graphs pressure versus thoracic volume. After those first 2 sections, we'll move on to the work of breathing, which flows naturally from understanding the Campbell diagram, because the work of breathing is essentially the area between the curves of the Campbell diagram, and that will become a little bit more clear when we get to that part. The fourth part of this lecture will then focus on mechanical ventilation and how the Campbell diagram can be applied to the ventilator, and how from ventilatory waveforms, or the waveforms that you can glean from the mechanical ventilator, you can use those as an analysis for work of breathing and for the static and dynamic components of intrathoracic pressure as well. And then following mechanical ventilation, the follow portion of this chapter will be a brief introduction to auto PEEP. So with that said, moving on to discussion of intrathoracic pressure and its subtypes, that is the static and dynamic aspects of intrathoracic pressure, I'm going to introduce to you the bag and tube model of the respiratory system. And this is the bag and tube model here. So this is your thoracic box outlining a nice little alveolus here, and this is an airway leading into the alveolus. And so this is a schematic for essentially the lung, and what the alveolus I will use to represent is the bag, or the static aspects of pleural and intrathoracic pressure. And then the tube is a schematic for the airway, and that's going to represent the dynamic aspects of intrathoracic pressure. And so this is the static pressure, the alveolar pressure, less the pleural pressure. So this is a transmural pressure, as we will talk about in Chapter 2 as it pertains to the cardiovascular system, as well as in other chapters, like in Chapter 6 when we talk about the central venous pressure, or the wedge pressure in Chapter 7. And this is a static pressure, the pressure that is only contributes to the genesis of volume, not to airflow. Then there's the dynamic pressure, and this is as represented by the tube here. And this is the body surface pressure, which is taken to be atmospheric pressure, less the alveolar pressure. So this pressure differential is what drives gas flow, and this follows, as we will see, essentially Puisoi's law, which defines flow as it pertains to pressure and resistance. So let's begin this first section of Chapter 1, and that's the static properties of the respiratory system. So as I've touched on briefly, the static pressure is the pressure within the respiratory system when there is no airflow, and this is a transmural pressure that's directly related to the volume of the distensible object and inversely related to the object's compliance. As mentioned, it describes the pressure gradient between the inner and outer surface of the distensible object, and it can really only be understood in the absence of airflow, that is, removing the dynamic component of the respiratory system pressure. And it's described by this equation with which most of us are quite familiar, and this is, again, a rearrangement of the compliance equation. So this is the alveolar pressure less the pleural pressure. This is the transmural or distending pressure, and it is equal to the change in the volume of the distensible object over the compliance of the distensible object. Again, this is a static pressure. There is no airflow. So I've made this schematic to represent the static pressure of the lung. You can see that I've removed the tube. That is, I've removed the dynamic aspect of the pressure here, and this only deals with this transmural pressure, that is the alveolar pressure and the pleural pressure, and this is the determinant of lung volume. I've mentioned this, the tube has been removed, and this pressure, alveolar less the pleural pressure, has a special name which I'll get to, and this is known as the transpulmonary pressure, the pressure in the alveolus minus the ambient pleural pressure, and this is a major determinant of lung volume. So the pressure required to keep the lung at any given volume is this transmural pressure, and it's the difference between the alveolar pressure and the pleural pressure. And as I mentioned, this is a very special pressure to pulmonologists and physiologists and intensivists, and this is known as the transpulmonary pressure. And this is really the pressure, the transpulmonary pressure is really the pressure that predicts barotrauma. In these ARDS patients, this is the pressure that predicts whether or not there's going to be alveolar and airway fracture, which puts you at risk for pneuma mediastinum and pneumothorax. And this relates the equation that relates the transpulmonary pressure to volume is, as I mentioned, the rearrangement of the compliance equation mentioned here, and that this is a static lung pressure volume relationship. This is like measuring sequential pressure volume points at no airflow. So it would be like taking a breath in, holding it, measuring the pressure required to maintain that volume, measuring the volume, taking another breath in, doing the same thing, measuring the pressure required to maintain that volume and measuring the volume. So it's sequential static pressure measurements. And this is a cartoon of what's going on. So if we were to start at point A, pleural pressure A, alveolar pressure A, lower the pleural pressure, you can see that the arrow is increased in thickness, which means that the transpulmonary pressure is increased. Again, this is done at no airflow. So what has happened? Well, the bag portion of the bag and tube model has increased. So the transpulmonary pressure has increased, so the volume will increase. And again, this is modulated by the compliance of the object. So the pleural pressure is lowered, the transpulmonary pressure is increased, and each measurement is in the absence of airflow. And this increase in transpulmonary pressure gives the tendency, not the absolute, but the tendency of the distensible object to increase in volume. And again, the tendency is modulated by the compliance. So if we imagine lowering the pleural pressure in the previous figure, as I mentioned before, in sequential steps while measuring the increase in volume after each decrement in pleural pressure, remember, as you're lowering pleural pressure relative to the alveolar pressure, you're tending to increase the alveolar pressure relative to pleural pressure, so there tends to be an increase in volume. If you're to do that sequentially, you could create a graphical representation of the pleural pressure lung volume relationship. The slope of this line is compliance, and as I mentioned multiple times in multiple other lectures, elastance and compliance are inversely related, so you can essentially use them interchangeably. So this is going to be a graph of the lung elastance curve, so it's very important here to look at what the different axes represent. So the y-axis is the pleural pressure here, and this is in centimeters of water, so this is negative denotes below atmospheric, positive denotes above atmospheric, and then the y-axis is volume of the lung, and that's in percent vital capacity. So if we were to do that experiment that I just mentioned where you sequentially lower the pleural pressure, so you're moving this way on the y-axis, and then at each point measure the increase in lung volume and plot it, well, then you'd get this nice curve here, and this is your lung compliance or lung elastance curve. And you can see there's this volume down here known as the equilibrium volume, and that is when the intrathoracic or pleural pressure becomes atmospheric or zero. The lung reaches its equilibrium volume, and if you were to go above atmospheric pressure, that is, have a positive intrathoracic pressure, you would maintain that equilibrium volume, and that is because the positive pleural pressure, or conversely you could look at it as a negative transpulmonary pressure. It's a little bit difficult to wrap your mind around this kind of double negatives, but this causes airway collapse. You can imagine as the positive pressure outside of the airways pushes down on the airways and collapses them, volume is retained within the lungs, so the volume doesn't ever really get to zero. It gets to this somewhat positive volume, and that is the equilibrium volume of the lung. So this elastance curve is really important to understand because shifts in this curve are the disease processes that we're dealing with in the intensive care unit all the time, particularly poor lung compliance, and that is a shift down into the left of that curve. So if you think of patients like with ARDS who have poor pulmonary compliance, to a certain extent, interstitial edema, alveolar edema in a patient with bad heart failure, this compliance curve shifts down into the left. So it gives a nice graphical representation of disease that we frequently see in the intensive care unit. And importantly, it relates the diseased lung with changes in intrathoracic pressure and lung volume, which are key mechanical mediators of heart-lung interaction. So understanding this graphically is imperative for understanding heart-lung interaction. And you can picture in your mind, and I'll show you in the next slide, that if the compliance curve shifts down into the left, that a decrease in pulmonary compliance tends to favor a lower pleural pressure for any given lung volume. So this is a qualitative analysis of pleural pressure with respect to lung volume in a given disease state, that is a lung with poor compliance. And it's just the opposite for an increase in compliance. So the slope of this curve, whether it shifts up and down, is determined mostly by surface tension And I talk much more about that in my book chapter. It's a little bit hard to graphically represent here, but this is determined by surfactant at the air-water interface of the alveolus, but also by the connective tissue content of the lung, which changes the slope of this curve. So you can imagine a patient with bad pulmonary fibrosis, and the lung is very fibrotic and poorly distensible, that you have a poorly compliant lung. It shifts it down into the left. Or if you have a waterlogged lung full of fluid with frank alveolar edema, that tends to impair surfactant and impair surface tension, then that will also shift the pulmonary elastance curve down into the left. So picture different disease states that you frequently see in the intensive care unit and how it applies to this pulmonary elastance curve. So just to reiterate graphically what we see here, this shift down into the left is represents a decrease in lung compliance. So you can see that there's a greater change in pleural pressure, so you must lower the pleural pressure to a greater extent to achieve any given thoracic volume. So for example, if you look at FRC here, well, the pleural pressure is not as low as when the pulmonary compliance is impaired. Conversely, an increase in lung compliance is just the opposite, and this is sort of like the emphysematous floppy lung. So for a given volume, actually, the pleural pressure tends to be higher. So I've basically already mentioned this, but I think I'm just going to show you graphically here what I just did. So if you were to look at 50% vital capacity, the pleural pressure for the normal lung elastance would actually fall here versus the pleural pressure required to generate the same volume in a lung with impaired compliance falls there. So that was the static properties of the lung, but you can do the same thing for the chest wall. And you may think, well, why do we need to care about the chest wall in the intensive care unit? How could that impair or affect your physiology? Well, it has very profound effects on your physiology, as I'll demonstrate and illustrate here. But changes in the thoracic cage itself, changes in the extrathoracic cage, like massive obesity or massive ascites, can profoundly affect the chest wall mechanics, which will alter your pleural pressure. And as I'll elaborate over the following chapters, changes in your pleural pressure does have very important effects on your cardiac loading conditions and plays a role in cardiocirculatory interactions. So it's imperative that you understand that the chest wall is an important mediator of pleural pressure, and that the pressure-volume relationship of the chest wall can be obtained in a very similar manner for the lungs. The relationship is a little bit more complex, but you can kind of imagine this by imagining a hypothetical lung-less system. If you were to just take the thorax itself and monkey with its pressure-volume characteristics and graph that, then you could create a similar curve for the chest wall as you did for the lungs. Also important when you're considering this diagram is that the pressure-volume relationship of the chest wall is obtained in the absence of any inspiratory or expiratory muscle activity. It's the passive chest wall. So you have to imagine doing this experiment in a chest wall, in a paralyzed chest wall. So the muscles of inspiration and expiration have no bearing on this relationship. So this is kind of my hokey diagram that we already saw. This is your chest wall, the bony chest wall, and like what we did with the lungs, changing the pressure, the pleural pressure surrounding the lungs and looking at the change in volume on the lungs, will do the same for the chest wall here. So this is your pleural pressure, this is an opening, and this is your body surface pressure. So if you were to imagine evacuating some air from the chest wall, so sort of sucking some air out, this would tend to lower the pleural pressure within the chest wall. Lowering the pressure on the inside of the chest wall will drive air out by a pressure gradient. And then what will that do to the chest wall? It will cause the chest wall to shrink in size. So this delta volume is the change in the chest wall volume when you've lowered the pleural pressure. Again, this is a passive chest wall. The muscles of inspiration are not activated here. This is just the, and if you were to just imagine an ex vivo chest wall that you were doing this experiment on, lowering the pressure within the chest wall and then measuring the change in volume, the decrease in volume of the chest wall that occurs as a result. So the chest wall, well, I think you can appreciate the chest wall will decrease in size because the pressure within is lower than the pressure without. So the pressure without will tend to collapse the chest wall. So then you can do just the opposite. If you were to add air within the chest wall, sort of blow into the chest wall and increase the pleural pressure inside the chest wall, well, as you would expect, the chest wall would tend to distend, and this change in volume here, again, would be modulated by the compliance of the chest wall. And so if the pleural pressure is greater than the body surface pressure, then the bony thorax will tend to increase inside. Again, in a passive chest wall. Muscles of inspiration and expiration are completely paralyzed in that situation. So by obtaining sequential changes in pleural pressure or the intrathoracic pressure and chest wall volume, a graphical relationship for the chest wall can be made, just as we did for the lung. And again, each of these measurements would be done in the absence of airflow. So you would make that pressure change, you would lower the pleural pressure or increase the pleural pressure, and then stop, and there would be a cessation of airflow, and then you would look at the pressure that's required to maintain a given equilibrium volume. And the pressure-volume relationship for the chest wall, as I mentioned, is done when the respiratory muscles are completely paralyzed. So this is a totally passive chest wall. So this is your chest wall elastance curve. You can see that it has somewhat of a different shape compared to the lung. The lung kind of was inverse in relationship to this. It moved up and to the left, whereas the chest wall elastance curve moves down and to the left, and that tends to make sense because as you lower the pleural pressure or you lower the pressure within the thorax, again, you are creating a vacuum within the thorax, so the volume of the chest wall will tend to decrease, and it kind of does so in this curvilinear fashion, whereas you get further and further out, it requires a greater and greater lowering of the pleural pressure in order to generate a smaller chest wall volume. And then above its equilibrium volume, as you increase pressure within the chest wall, the passive chest wall, the volume of the chest wall tends to increase in size. So, like the lung, as we saw, that changes in lung compliance, the changes in the pulmonary elastance or compliance curve shifts up and to the left, down and to the left or up and to the right. The same thing can be said for the chest wall. The chest wall will shift based on changes in chest wall compliance. So a shift down and to the right of the chest wall compliance curve, or elastance curve, depicts a decrease in chest wall compliance, while a shift up and to the left is an increase in chest wall compliance. Again, it's kind of just the inverse of the pulmonary mechanics. And the slope of this curve is multifactorial, as I mentioned, but it includes the bony thorax, its articulations, as well as the activity of the muscles of respiration and the abdominal pressure. I feel like in the intensive care unit, the abdominal pressure is one of the key determinants of chest wall compliance. So this is your chest wall elastance curve. So this would represent a decrease in your chest wall compliance. And you can see here that a greater pleural pressure is required to affect any change in thoracic volume. So you can see compared to this curve, moving the pleural pressure from atmospheric to slightly negative, while doing the same thing for this chest wall elastance curve making the same pleural pressure drop results in a much smaller volume change in the chest wall. And you could imagine massive obesity or massive ascites as being an etiology for that curve. An increase in the chest wall compliance curve is essentially just the opposite. So a smaller change in pleural pressure is required to affect any change in the volume of the chest wall. So inspection of the chest wall curve reveals that this decrease in chest wall compliance curve favors a higher pleural pressure. As we just saw, if the curve shifts down and to the right, then it tends to favor more positive pleural pressures. Whereas, a decrease in the chest wall compliance curve also tends to decreases equilibrium volume. And this typically occurs when the decrement in chest wall compliance is extrinsic to the chest wall cavity. In some of the older literature that looked at chest wall compliance in the elderly, healthy, non-obese elderly patients, there is a decrease in chest wall compliance, but the chest wall compliance curve, while it shifts down and to the left, it also shifts upwards in parallel. So there can be a higher equilibrium volume or a higher FRC even though there is a decrement in chest wall compliance, and that is not due to extrinsic compression of the chest wall by obesity, but due to changes in the intrinsic bony articulations of the thorax. So if we now integrate the two curves that we just learned about, the lung and the chest wall elastance curves, we can create the Campbell diagram. And the point at which the inward recoil of the lungs matches the outward recoil of the chest wall defines the resting lung volume, and that's the functional residual capacity. And as we saw, the equilibrium volume of the chest wall is much greater than FRC, but the equilibrium volume of the lungs is lower than FRC. So at this equilibrium point, at the end of an expiration at FRC, the chest wall tends to recoil outwards and the lungs tend to recoil inwards. And that can be seen on this diagram here. Here's the equilibrium volume of the chest wall and the equilibrium volume of the lungs. And for those of you who've seen an open thorax surgery, like a CABG or any open heart surgery, when the surgeons cut the sternum and open the chest wall, well, the chest wall tends to spring open, spring outwards, and that's the chest wall trying to reach its equilibrium volume from FRC, and the lungs tend to recoil inwards when the chest wall is open, because when you open the thorax, you essentially make intrathoracic pressure atmospheric pressure. So you'll change the pleural pressure just before cutting open the sternum from negative to atmospheric right when you open it. So the lungs recoil in and the chest wall recoils out to reach their respective equilibrium volumes. And the point at which they intersect is functional residual capacity, and then the healthy normal adult, whoever that is, that tends to be about 35% of the vital capacity. So to increase the volume of the thorax, say from FRC to 50% vital capacity, the muscles of inspiration are activated. So when the muscles of inspiration are activated, the pleural pressure is reduced and the lung follows the lung compliance curve. So if we were to just talk about changing volume and say nothing about driving gas flow, to go from FRC to 50% vital capacity, you'd move from there to there as demarcated by the fancy little moving arrow. So the pleural pressure, you can see, has decreased from, say, -5 to negative whatever, and the volume of the thorax is increased from 35% to 50%. So this is your change in pleural pressure for a change in volume. Now it's a little bit confusing because this chest wall compliance curve, as I mentioned, this is a passive curve. So this curve is generated when the muscles of inspiration were paralyzed or completely inactive. So some people say, well, how is this curve, how are we moving from here to here, from here to here when the elastance curve is totally static? And that's true. What's really kind of happening is that during an inspiration, the chest wall elastance curve is actually changing as the muscles of inspiration are activated. So to see that again, if you were to inspire from FRC to 50% vital capacity, you activate the muscles of inspiration to lower the pleural pressure. The chest wall elastance curve changes as you're generating this breath, and where it meets the pulmonary elastance curve is your new end inspiratory volume. But for simplicity, the Campbell diagram maintains the passive elastance curve on the diagram as a static, non-changing entity. So the pressure difference between the two curves, between the static passive chest wall elastance and pulmonary elastance curve, this lateral distance here, this pressure as outlined on the x-axis, this pressure between these two curves is the amount of pressure that must be generated by the respiratory muscles to achieve that given volume, and it's marked here by this orange arrow. So from the Campbell diagram, we can see that either a decrease in lung compliance or a decrease in chest wall compliance requires a greater change in the static pressure to achieve and maintain a given thoracic volume. So if the lung compliance curve shifts down into the left, or the chest wall compliance curve shifts down into the, sorry, I have that backwards. If there's an impaired pulmonary compliance or an impaired chest wall compliance, the elastance curves tend to separate, and I'm going to illustrate this on the next slide so it'll be less confusing. But as these elastance or compliance curves tend to separate, the lateral distance between the two, that is the pressure required to generate any given volume, must increase. But it's important to note, and this is a key point, that a decrease in lung compliance has a qualitatively different effect upon the pleural pressure than a decrease in chest wall compliance. And I'm going to illustrate this on the next slide, because as we mentioned before, low lung compliance favors a lower pleural pressure, but a lower chest wall compliance favors a higher pleural pressure. This is an imperative point for multiple chapters to come. So just to illustrate this effect, this is going to demonstrate a lowering of pulmonary compliance. So if we were to decrease the lung compliance, shift this down into the left, you can see that we've increased this lateral distance. We've increased the amount of pressure that must be generated by the muscles of inspiration to affect this volume change. And you can see that from here to here. But you've also lowered the absolute pleural pressure that must be generated to affect this volume. And that is graphically illustrated by comparing the point at the same volume, the pleural pressure that must be generated with a lower lung compliance versus a normal lung compliance to affect this volume. So this is a lower pleural pressure must be generated. Okay, so one last point is that the decrement in lung compliance tends to also favor a new lower functional residual capacity, and that's demonstrated by that point there. But what about a decrease in the chest wall compliance? Well, it too requires that the muscles of respiration generate a greater pressure for any given volume. And that is illustrated here. So this is a decrease in the chest wall compliance, massive obesity, intra-abdominal hypertension, massive ascites. So the chest wall compliance is impaired. It shifts down and to the right. Again, the lateral pressure between the two curves has increased. So to achieve this volume, a greater pressure must be generated by the muscles of inspiration compared to the normal chest wall compliance curve. But look at the qualitatively different effects on pleural pressure. If the lung compliance were to remain perfectly normal in this patient, which I'd like to emphasize is rare in patients who have decreased chest wall compliance in the ICU. Patients with decreased chest wall compliance in the ICU also have comorbid impairments in pulmonary compliance, but just for the sake of illustration, we're going to maintain lung compliance in the normal range. This lateral pressure has increased, but the pleural pressure here, okay, has not changed for this given volume. So as I've mentioned, there's no change in lung compliance. So in the spontaneously breathing patient, the pleural pressure required to maintain this volume is just the same as in the patient with the normal lung compliance, okay? Even though the pleural pressure decreased, the absolute pleural pressure that must be achieved to maintain this volume is the same, the work or the amount of pressure that must be generated by the muscles of inspiration is greater. in the patient with lower chest wall compliance compared to the patient with lower normal chest wall compliance. This is a key point. The drop in pleural pressure, the absolute number, the absolute pleural pressure that must be achieved to affect this volume change is the same as the patient with normal lung compliance, but the amount of work, or the amount of pressure that must be generated by the muscles of inspiration is increased, and that's because the muscles of inspiration must now overcome this stiff chest wall. So comparing the pleural pressure there, as I've mentioned. And also these acute decrements in chest wall compliance also tends to decrease the FRC, and that's illustrated by moving the FRC from there down to there. So this is the end of the first portion of Chapter 1, and this has been an in-depth discussion of the static aspects of the lung and chest wall, that is the static components of the respiratory system, and the pressures that must be generated intrathoracically to affect a given change in volume of the thorax. But again, this entire discussion completely negates the pressure that must be applied to generate airflow, and that is what Part 2 of Chapter 1 is going to deal with.